Welcome everybody to webinar number 2, season 5, Cystinosis, the child as a whole. I can't tell you how glad I am that we're back doing these webinars, and we have an amazing panel for you today to talk about what is, although a rare condition, a condition that affects our patients in a particular way. It gives me a tremendous amount of pleasure to introduce Professor Paul Grimm, Professor of Pediatrics, Medical Director of the Pediatric Kidney Transplant Program at Stanford School of Medicine and Stanford Children's Health Center for Academic Medicine, and Pediatric Nephrology. I came across and met Professor Grimm about 1.5 years ago, and I was really taken by his practical knowledge and all the questions that I had about the kids that I looked after. He just put everything and crystallized everything in a phenomenal way, and I think you'll see that is the case. Well, what do I need to say about Professor Dominique Bremont-Gignac? Not only is she an outstanding pediatric ophthalmologist, she's the head of the department of Necker University Hospital for Sick Children in Paris, and also heads the Opthara Rare Eye Diseases Center there, and also is heavily involved in the rare disease network in Europe. And she is my co-moderator. I'm going to hand over to her to introduce the rest of the panel. Hi, Dominique. I hope ça va?
Ça va très bien. Hello, Ken. It's a pleasure. Hi from Paris. A pleasure to have you in the panel, of course. So how can I present you? There is no need for that, but Professor Ken Nischel is the Division Chief Pediatric Ophthalmology and Strabismus, Medical Director, Digital Health in UPMC, a Children's Hospital in Pittsburgh. So he is also Assistant Medical Director of UPMC International. He's Executive Vice Chair, UPMC Department of Ophthalmology. So no need to present him, but of course, every time he's so great. So we have also on the panel, and thank you very much, Phoebe Leonard. She's Associate Professor for the Department of Ophthalmology at Emory University School of Medicine. She joined the section of Pediatric Ophthalmology and Strabismus in 2009. Her clinical interests include pediatric anterior segment, keratoplasty, pediatric cataracts, pediatric and adult strabismus, and global pediatric eye care. Thank you, Phoebe, for sharing this panel and being there. So the important question is, you will ask questions. So for the audience, type your question on the YouTube comment section. So we will be very happy to answer. And this is the best way to send us questions. And also, you can get attendance participation certificate. Please send an email if you need that to administration, to admin@wspos.org, and you will get your participation certificate.
Okay, I think I'm going to kick things off very briefly. For those of you who don't know, it was Rare Disease Day on the 29th of February. And of course, cystinosis is indeed a rare disease. These are my financial disclosures, none of them pertinent to the program today. Cystinosis is rare. It's like a 1 in 100,000 to 1 in 200,000 live births. There are around 600 children, adults in the USA that are affected. I still go back to this article that was published, I think it was around 2012, a review article in the New England Journal of Medicine about cystinosis, and some of the images that will be used are from that actual article. There are 3 clinical forms based on symptoms and age of onset. There's the infantile cystinosis, characterized by renal proximal tubulopathy, and I'm not going to talk anything more about that. I've got a world expert on the panel. A juvenile form with the markedly lowest rate of progress, and then an adult form with mainly, but not only, ocular abnormalities. One of the things that has really struck me as I have sort of looked after children who've become adolescents, and actually I had a couple of adults when I was at Great Ormond Street, is that with the availability of treatment and renal replacement therapy, nephropathic cystinosis evolved from an early fatal disease to a chronic progressive disorder with potentially high impairment. And I think that, as we all know, your vision has a large effect on your quality of life. And so I think one of the things that I hope will come from this webinar is, we'll understand how we can detect this condition earlier in terms of visual involvement and not just the cornea, treatment strategies, and better communication really with a multidisciplinary team. WSPOS sent out a huge message on Rare Disease Day about cystinosis. And remember, Rare is strong, it's proud, it's many. And I would like to thank very much at the beginning of the webinar, Todd, who helped support the platform for the webinar. And this webinar has been made possible by a educational grant from Recordati Rare Diseases. So on that note, I'm going to stop sharing, and I am going to invite Professor Grimm to share his slides.
Thank you, Ken.
Thank you very much, Ken. This is really exciting to be here, and I'm very, very looking forward to the presentations and, most importantly, the interactive discussion between the audience and the guests on the panel. So I'm a pediatric nephrologist, but I started out my career as a rural family doctor in northern Saskatchewan, delivering babies and sewing up farm injuries hundreds of miles away from a large center. So I do understand the importance of having a breadth of knowledge about a little bit about everything. And then in my training, I saw one cystinosis patient my entire training, but I learned about it over time. Cystinosis, as Dr. Nischel described, is a rare disease, estimated between 1 in 100,000 or 200,000 live births. Various papers say anywhere from 500 to now 800 people in the U.S. have it. More than 2,000 identified cases worldwide, but this is notoriously underdiagnosed. 95% of the patients are diagnosed as an infant or in early childhood. The typical North American child with cystinosis has blonde hair, but in other ethnicities, dark hair and pigmentation may or may not be affected. Untreated, without any treatment, children with cystinosis pass away around 10 years of age, and the cause of death is kidney failure. But with treatment for end-stage kidney disease and cysteine depleting therapy, there are now patients in their 50s and doing well. So I run a consultation clinic, and I've seen over 100 unique patients with cystinosis from these various states and some other parts of the world as well. And a lot of what I've learned is simply acquired through seeing patients, and the patients have been my teacher, that's for sure. So the broad picture, the cystinosis is a disease of the lysosome. And the lysosome can be thought of as a recycling plant, taking broken down proteins and other materials from the cell, breaking those proteins down into their constituent parts, and then recycling them to be used by the cell. So just imagine, say, for example, in this recycling plant, you see a truck full of paper leaving the recycling plant, going on to be used in some other creation. But what happens if the paper truckers go on strike, but the front office of the recycling plant keeps accepting deliveries? The paper builds up and builds up until paper is everywhere, and it starts preventing the normal functioning of that recycling plant. And sooner or later, that leads to disaster. And that's an excellent analogy about cystinosis. So in this cartoon, the circle here is a cartoon of a cell lysosome. And cystinosis is a disease of impaired transport of cysteine. So here we have the cystinosin is the protein. Now, the protein is the pink structure in the membrane, and it transports cysteine out of the lysosomes. That's its primary function. When there's defective function or absence of cystinosin, there is defective cysteine transport, and cysteine starts building up and building up. And that buildup of cysteine then causes the lysosome to rupture, cysteine to be spilled into cells, which then in turn die, and the cysteine is released into the extracellular tissue, leading to crystals present throughout the various tissues of the body. And these are just some pathology examples of these crystals. So, cystinosis is a genetic disease of the CTNS gene located on chromosome 17, which encodes the protein cystinosin. It's a lysosomal membrane protein with 367 amino acids. Over 100 different mutations are known. And this is a picture of the protein, and it's your typical 7-transmembrane domain channel pump, which sits on the lysosomal membrane. And each one of these colored beads is an identified mutation. The most common mutation in the United States is the Northern European mutation, which is a 57 kilobase deletion that removes not only the cystinosin gene, but some adjacent genes, including genes for things such as pigmentation. Some forms of cystinosis have a partial function of that genetic abnormality, and that leads to later onset, such as the childhood onset. And some of these abnormalities have been identified to be associated with the primarily ophthalmologic onset cystinosis, which, as if you wait long enough and follow these patients long enough, there may be systemic manifestations. This is a picture of children at a cystinosis gathering. Every single child in this picture has cystinosis. And I wanted to point out children of African heritage, children of Asian heritage, and Hispanic heritage can have cystinosis. And American pediatricians often are only presented images in the textbooks of the classic blonde-haired child from the Northern European deletion. And so diagnosis in children of other races is actually sometimes delayed. And this is a DEI problem. And I point this out because it's present in all races, all ethnicities, and all backgrounds. The complications of cystinosis vary by age. In infancy, the presentation is the renal Fanconi syndrome, which primarily presents with polyuria and failure to thrive and growth retardation. In slightly older children and into adolescence, we start seeing photophobia in the school-age child, hypothyroidism, GI disorders, kidney failure. And for these people who live long enough because of either initiation of end-stage kidney therapy, such as dialysis and transplant, or cysteine depleting therapy, it is truly multi-system with retinal blindness, myopathy, and aspiration pneumonia, which may be the cause of death for many of these patients, diabetes, memory loss, concentration difficulty, lung dysfunction, muscle weakness, and hypogonadism. In infancy, a pediatric ophthalmologist may see a child presenting for investigation of failure to thrive or rickets, and you can see these marked bowing of the lower extremity and widening of the epiphyses and delayed bone age. Many of these children have generalized ligamentous laxity with marked flat feet. And that's something which is not well explained, but it's often a problem that prevents them from exercising without proper foot care. So if as an ophthalmologist, you might look at the other end of the patient and comment on their flat feet or recommend foot care, you would be doing them a service. For people that live long enough, especially if they don't regularly use their cysteine depleting therapy, they develop a progressive myopathy. The first manifestations are often seen in teenagers as a distal myopathy. And in this patient here, there's a deficiency of the interosseous muscle between the thumb and the index finger here. And in this patient of African heritage here. So this is a classic first presentation of the distal myopathy, or if you have them point their hands to you like this, like they're cupping, you see a flattening of the thenar and hypothenar eminence. As it progresses, it becomes more proximal, and you can see the deficiency of the suprascapular, infrascapular, and deltoid muscles in this patient who is unable to raise their arms to comb their hair or brush their teeth as a late manifestation of cystinosis. But getting back to the pediatric world, the main presentation is the Fanconi syndrome. Fanconi syndrome is injury to the proximal tubule, which presents with one symptom, and that's polyuria. On investigation, you see urinary losses of all of these things, amino acids, glucose, phosphate, sodium, potassium bicarbonate, calcium, low molecular weight protein, and uric acid. This is amazing work from the early 1950s where investigators microdissected the kidney tubules of humans dying from various diseases. And this is a normal newborn tubule with a glomerulus here and the tubules showing lots of cells throughout the tubule. In this patient who died of probable cystinosis with Fanconi syndrome, there's the glomerulus here. And all you see is this basement membrane with no tubular cells in the area of the proximal tubule. So this was thought to be like a swan with a very thin neck that with the head bobbing around. And so that's why it's called the swan neck deformity. But it clearly demonstrates the lack of tubular cells, proximal tubular cells primarily in a patient with cystinosis. So the presentation is polyuria. The kidney is unable to concentrate the urine. The baby must excrete huge volumes of dilute urine. Their extreme thirst causes them to refuse formula, breast milk, and other foods. And moms often realize this before the doctors. This image is a child presenting with severe dehydration from cystinosis. This is the same child 24 hours later after rehydration, showing what a difference in the appearance. Now, cysteine depleting therapy is very important in the treatment of ocular disease and systemic disease. So in this cartoon, we go back to the cartoon of the lysosome with the damaged or defective cystinosin and the cysteine buildup. The drug is called cysteamine. Cysteamine is taken orally or topically. It gets into the cell, into the lysosome, binds cysteine, and then tricks a different pump, the cationic amino acid transporter, known as the lysine transporter, to pump the cysteine and cysteamine unit out of the cell. And this effectively depletes cysteine from the lysosomes, and if started early enough, can have a profound effect on the patient's life. This is a graphic showing age on the bottom, X here, and estimated GFR on the Y-axis. This is the trajectory of patients never treated with cysteine depleting therapy, showing that by the time they're age 10, their GFR is low or they have died or are on dialysis. For patients that are diagnosed with cystinosis, started on cysteine depleting therapy, but with poor adherence because this drug is difficult to take, their GFR is higher at any given age, and more of them have life sustaining kidney function getting longer and longer. For patients who are diagnosed and are able to take therapy well, it's available, they can pay for it, and they don't have too many side effects, you can see their GFR is better and keeps them off of dialysis and transplant longer. But for the small group of patients where they're the second child in the family, so they're diagnosed at birth, pre-symptomatically, their estimated GFR is basically normal. So with very early initiation of cysteine depleting therapy, their kidney disease can be, at least kidney failure, can be prevented. Early treatment with cysteine and the cysteine depleting therapy improves brain function. So this is the total IQ of an older children, depending on when they started cysteine depleting therapy, showing the IQs are much better with an early diagnosis and progressively go down with later diagnosis. And there's abnormalities in the brain, which the neurologist can point out. But therapy is hard. There's a huge pill burden because cysteine depleting therapy, cysteamine, undergoes intensive first pass liver extraction. So this is a typical dose of cysteine depleting therapy alone, given twice a day for a child. And this doesn't mention all the other supplements that are needed to deal with the renal Fanconi syndrome. This chart is a typical patient day with various drug doses, feeds. So there's something happening about every half hour throughout the day. For a child with cystinosis, this often means one of the parents has to quit work, or there has to be some caretaker full time dedicated to their care because of the intensity of the therapy. This is important when it comes to having some mercy and compassion in dealing with these patients, because when you ask them to do something new, they really have to need it. We're starting to understand the concept of time toxicity. Now, time toxicity was first thought about and discussed in the context of cancer treatment. When you think of all the time it takes to go to the doctor, spend in hospital, clinical trials. But we're now thinking about this in the context of dealing with chronic illness management. Time is our most precious commodity, gift, or resource. Caring for a child with chronic disease requires time, medication preparing and taking, visits to all the various subspecialties that are involved, lab testing, radiology, developmental testing, and therapies such as speech and OT. And so, what this means is, I want you to keep in mind the huge demands on these families, especially at diagnosis. So, at diagnosis, these children are vomiting, they have failure to thrive. And I believe the most important thing is to get them nourished because the brain has a critical period of growth where if they're malnourished, they may have cognitive defects they will never recover from. So when I start seeing these patients, we focus on the supplements and on feeds, then on cysteine depleting therapy. And I believe sometimes starting the topical treatment, the drops at the diagnosis, just adds to the tremendous complexity and overwhelming nature of this. We know that parents are overwhelmed by the critical medications, nutritional supplements, tube feeds. And we also know that delaying topical therapy for a short period of time, when you do start it, it can deplete corneal crystals very well. The original studies of topical cysteamine on the cornea included patients up to the age of 30, and it showed a year of good therapy with good adherence caused excellent depletion of the cornea. So I don't believe there's any good reason to start right away at diagnosis if the corneas are relatively clear, and especially when the patients are and their families are grappling with all of the demands. That can be delayed a few months or a year or something like that. The other thing I was asked for a pearl for the ophthalmologist is that just to be aware that adequate crystal depletion can be accomplished with less frequent drop administration than the approved labeling. So for Cystagon, which is the originator drops, the FDA approval was once an hour while awake. And the study was done by people trying to think of what is the, we want to prove this works. So how much can we ask these families? And so they just said every hour. And so that's the labeling in the US and the FDA. But no studies were ever done officially to show what is the fewest number of drops that are needed. We know from clinical experience that many of these patients do very well with less than the recommended number of drops. So just be aware that that the that crystal depletion, if they're doing well, doesn't mean they have to have the drops every hour. And one of the things I tell families is do not work heaven and earth to get drops being administered at school. Many of these adults tell stories about having to go to the school nurse every hour during school and being identified as a strange child or a problem child. And it was one of the things that aggravated and made it difficult for their psychosocial development. We do it before and after. The other thing I'd like to point out is the absence of corneal crystals in infancy doesn't rule out cystinosis. In some parts of the world, they don't have access to biochemical testing like white cell or granulocyte cysteine. And so if the pediatrician suspects cystinosis, they'll send the patient to you for a diagnosis. And we know that early on, some patients with cystinosis may have very few crystals, or the crystals that are there may be very peripheral, and you can only see them with a good dilation in the slit lamp, which is really hard for a squirming 16, 18-month-old. So because they may be rare and peripheral, you may not see them. If you report the absence of crystals in a patient like this, always include the caveat that cystinosis is not ruled out. And it's important to do follow-up exams because some of the pediatricians may not know that. And I've seen patients where the diagnosis of cystinosis was delayed because the pediatrician sent the patient to an ophthalmologist. The ophthalmologist said, I see no crystals today. And the pediatrician took that to believe that it wasn't cystinosis. And it was not until years later, and a lot of potential treatment was lost. So, so those are the points I wanted to make. And thank you for the time. And I'm now going to turn over to the rest of the team, and I'll stop sharing.
Well, Paul, thank you so much. That is probably easily one of the best lectures or talks I've heard on cystinosis It was superb. Thank you so much. Before we open the discussion, I just want to let everyone know a big hi to everybody. One of the things that we like to do is find out where our listeners are from. Get a hold of this. We have people listening from Poland, America, Suriname, Sweden, Lebanon, Egypt, UK, France, Bahrain, Malaysia, Honduras, Argentina, Brazil, Mexico, Kenya, South Africa, India, Belgium, and Canada. Isn't that wonderful? So a truly global village right now. So questions. we off air before we came on, I asked Professor Grimm this question about the fact that I had noticed recently that when children were taking systemic histamine, that they often had this aroma, and we get to smell it because we get up close and personal when we're examining the eyes. And I recently noticed that that wasn't the case. And I put that on the chat on the YouTube. And one of my colleagues, actually, Sas Biswas, who I'm going to quote one of his papers, said that he hadn't noticed this recently. He hadn't noticed this. But Professor Grimm, can you explain why we might be not noticing the aroma so much?
So this is funny because as was just said, you get very close to the patients when you're doing slit lamp and other examinations. So you would be the best people. In fact, someone should have done a study about the ophthalmologist's thoughts about this disease. So the originator cysteine depleting therapy, Cystagon, is a immediate release pills or liquid. And in the stomach, it releases volatile sulfur. And so these patients often have gastroesophageal reflux because cysteamine is quite harsh on the gastric mucosa. And so they burp. And so you smell the sulfur in the burp. The more recent drug, which is enterically coated, Procysbi, the beads are pH dependent. And so when they get the pills, the beads stay intact. And only once they get into the small bowel and the pH becomes alkaline do those beads release the cysteamine. And so the sulfur is much farther down the intestine, and it's very less likely to be in the stomach and then belched. So the burping is less. There still may be a bit of a smell in the secretions, but it's much less in patients with Procysbi. Problem is it's not available everywhere in the world. It's very expensive. Some countries have made the decision not to fund, and some insurers don't fund. So depending on the part of the world you work in, you may or may not be aware of Dr. Nischel's observations.
That's brilliant. Thank you. So Phoebe, Dominique, anything you'd like to raise with Professor Grimm?
Just a question, because my question was, I think also we did diagnosis with ocular involvement before renal failure. And so that's why ophthalmologists are really important, I think. What do you think?
Absolutely.
Do you have some cases from your experience?
Absolutely. There are patients where they have not been diagnosed by their primary care and pediatricians, and they go for an ophthalmology appointment, and the ophthalmologist sees these crystals, and it's the investigation and management. We also think that there's a lot of cystinosis in older people that's not diagnosed. And I was involved in a study which was presented in abstract form where they looked at the DNA of 4,000 dialysis patients in a dialysis unit called DaVita in the United States, and simply did cystinosis gene testing and found a couple of cases of cystinosis. But the patient's diagnosis was not cystinosis, it was FSGS or unknown cause for kidney failure. These were de-identified, and so we couldn't go back and find these patients. So it is likely that there are patients on dialysis or with CKD where cystinosis has not been recognized, and the ophthalmologist may be the first to make that diagnosis. So just be aware if you see crystals in someone who has any kind of kidney story, they may be undiagnosed.
Thank you. That's incredible.
Phoebe?
I also wanted to say thank you, Dr. Grimm, especially for the points that you made specifically for ophthalmologists from nephrologists. I think those points are extremely important. It's helpful to know that topicals don't need to be started at the time of diagnosis. I think that's an important point, that you can wait months and even a year, if the corneas are relatively clear to begin with. That's very helpful. Also, the fact that some of the children can do okay with, slightly less than the actual dosing schedule is very helpful. And I think those are important points to stress. I think it's easy for us to get caught up as clinicians, making sure that all doses are achieved. And I think you pointed out nicely the negative psychosocial impacts that can have for children at school and how disruptive that can be. Also, I think it is helpful to think that when we're referred infants to, quote, rule out cystinosis, it is really important to document that just because we're not seeing crystals at the time of diagnosis, that it doesn't rule out the diagnosis, and that probably a subsequent exam should be performed. So I don't have anything to add, but I'd like to just stress that those points that you made are very helpful to ophthalmologists, especially those who aren't as familiar with seeing kids with this condition.
Yeah, I mean, I have to admit, I feel a bit embarrassed, really. I mean, I've been looking after children with cystinosis since 1998. I worked with William Van Toff in Great Ormond Street, and it never occurred to me to say to the parents, you don't have to put the drops in at school. I think that's such an important point and something had never occurred to me. So thank you for that. Can I ask, when I was in the United Kingdom, we had a very strong network of pediatric ophthalmologists. It's a smaller country, there's socialized medicine. So there were, if you like, clinical effectiveness guidelines to help people work out, how often they should see an ophthalmologist. Nephrologists had access to ophthalmologists really quite easly. But since I've come here to the United States, because of the size of the country, because a lot of these children, I have a lot Amish children who are affected, and they're in communities where to get to Pittsburgh or to get to Philadelphia, it's a real whole day's worth of traveling sometimes. How is it from your side of the fence, where you've got the pediatrician, the nephrologist? Do you find access to ophthalmologists who are familiar with this condition is reasonable, or do you find that it's difficult because of the fact that some of these kids are in rural communities?
So the access question is like the bigger question in the United States about the variability of care depending on rural, urban, how close are you to a center that looks after children. Many of these patients live in small communities, and they cobble together local care providers who have never heard of cystinosis. Their pediatrician, older people have a primary physician or internist or GP who is trying to coordinate their care, and they're looking it up to date at night to find out about it. This is a problem, and we don't have the same regionalization that they have in areas of socialized medicine like in the UK or in Canada. So in the US, patients often find they have to cobble together care, and often they find a specialist for ophthalmology or others by talking to friends with the same disease on social media. So there are some parent organizations who do have some lists, or sometimes it's just word of mouth, and they will spend a lot of money, and they don't have much money sometimes to travel to a different state or different place for a one-off care. This is a problem. It's a real problem in places where we just don't have good distribution of care.
So one of the things that the pandemic was a real pain in the neck, as we all agreed. But one of the things it did was it made us open our eyes to the ability of delivering care digitally. And one of the things that I do with one of my Amish family, they go to a friend's house who's not Amish, but allows them to use their computer. And I'll just do a check-in to see if the child's photophobic, how the child's doing from the eye point of view. Are they straining? The parents think their functioning visually has changed at all? And then I end up seeing them usually once a year, but we get 2 telemedicine visits in between. So I wonder if that's something that we could utilize if we can develop a network, not just in the United States, maybe across the world, where people who have expertise can help local doctors with a sort of a second opinion system. It would be great. What do you think? What do you think? Would something like that be helpful?
So we have the technology is available, and people talk about personalized medicine. And what you're describing is truly personalized medicine, bringing care that they need where they are when they need it. And so using technology to get the care to them is so much better for the patients and easier if it can be accomplished. So this is personalized medicine. It doesn't have to be a high-tech lab test, that's for sure.
That's great. So we're going to come back. I think there are some questions that I think. So Dr. Tibrewal from New Delhi, who I know very well, has put a great question on. I think we'll leave that until Dominique and Phoebe have spoken, and then we'll get Professor Grimm's opinion as well. Before I introduce Dominique, so we have people from the Philippines, Pakistan, Serbia, Holland, and Slovakia. I've said Slovakia, haven't I? Oh no, and Slovakia are listening right now. So it's the numbers are getting bigger and the global reach is getting bigger. All yours, Dominique.
Thank you very much, Ken. I will share my screen and you tell me if you see that. I hope you can see it.
Yes, we can.
All right, very good. So thank you very much. And just from Paris. So we will see what is ocular involvement of cystinosis, and also what it's interesting to have a rare eye disease center and a rare disease network in Europe. So, I think it's when you see just one cystinosis, you can't forget it. So that's why it's quite complicated, because it's really complicated. And so we have a definition of a rare disease. It's 1 for 2,000. And the problem of rare eye disease is very heterogeneous, and it represents really a cause of visual deficit and visual handicap. So I really think it's interesting because to have that in a network. And so we have seen that there is gene therapy and innovative therapies that are coming with new molecules. And that's why we are talking about that for cystinosis. And for the majority of the anterior segment disease, it's less than retinal dystrophies, but studies are really still emerging with a preclinical stage. So I really think it's good. So I try to go back. Okay, so cystinosis affects the lysosomal storage system, as you have seen with Paul, and accumulation of cystine in the lysosome and characteristic crystals. So this really appears in ocular involvement. It's essential because it's visible and it makes really the diagnosis in some cases. When you look at what are the clinical symptoms, it's photophobia, it's contrast sensitivity loss. Of course, contrast sensitivity loss, it can't be identified by children. There is also for, in what its evolution cases, superficial keratitis. When you look at the slit lamp, you have needle-shaped reflective corneal opacities. And as I said, when you have seen once, you can't forget that. And usually it's diffusely span in the entire cornea. It begins usually by the periphery of the cornea. It may be observed before 1 year of age. But suppose that by 16 months of age, all presents corneal crystals. So there is one point is a major ocular treatment now by cysteamine, hypochloride eye drops. And you can see here, and I was part of SCOP 2 study Cysta drops to the safety and efficacy from patients from 6 months to less than 2 years old. And of course, one point is essential is the compliance, and Phoebe will talk about. So what we can see in in infants, the photophobia is really moderate. And which is important is the corneal crystals. And when you see here, it doesn't appear so obvious when you see in the slit lamp. But when you in the slit lamp directly, but with a diffuser, but when you see with a real slit lamp, so you can see the crystals. And so you can observe, and it's sometimes difficult because there is photophobia and sometimes complicated. And for children, you may be beneficial of a handheld slit lamp. In older children, untreated, there is severe photophobia. And also there is visual acuity that can decrease. There is contrast sensitivity deficit. There is superficial keratitis because the ocular surface is affected. And in the slit lamp, you have increased density of the corneal crystal and diffusely spanning the entire cornea. So just look at this chart. It was before a treatment a long time ago, because I've seen cystinosis since a long time also, like Ken. And he was very photophobic, and he has a lot of crystals also. He has also corneal involvement with mild superficial keratitis, but really ocular surface was affected, and lubricants appears very important also to treat the children. When we go to in vivo confocal microscopy from Antoine Labbé, a publication, you can see the crystal, and they appear in the epithelium, they appear in the anterior stroma, in the mid stroma, in the posterior stroma, and disparate membrane. So it appears they are everywhere in every layer. If we have evolution also, you can observe iris crystals in late patients affected. And the last point is retinal involvement. And in the fundus, you can have crystals, you can have depigmentation and pigmented remodeling on the fundus, and pigment migration and destruction of the photoreceptors outer layer. So it is very, very important. So sometimes it's not very obvious to see here the crystals. But when you go to OCTA, you can see here crystals, and this is really specific. So cystinosis is obviously a rare eye disease, and we have a network of a European network of rare eye disease. There is more than 900 rare eye disease, and coordinated by Strasbourg for all Europe. There is 24 countries, 52 full centers, and 8 affiliated partners. And so you can see here, I'm in charge of Oftara Center and in charge of coordinating 20 centers in France, and oversee also in Guadeloupe and French West Indies. This is the organization, and you can see there is a pediatric ophthalmology work group, of course. And this is the detail, but I will not go long time for that. And we have meetings and production of some papers, and can remember also because he was part of one of those. So cystinosis treatment has really changed by the ocular prognosis, and it's really very, very interesting for that. The point is, diagnosis may be done only with ocular clinical examination, and regular checkup are mandatory when you know there is a disease, of course, and of course renal also. And the cysteamine eye drops need to be delivered at least 4 times a day, to my thinking. And ERNI connects European ophthalmologists, and I hope WSPOS connect all world pediatric ophthalmologists. And you have here my team in Paris, and they support me. Well, I don't know in what extent, they support me every day. So thank you very much for your attention. I hope you have many questions.
Fantastic, Dominic. We do have lots of questions, but I think what we'll do is we'll move on to Phoebe's talk, and then, which I think will be really pertinent to some of the questions. I'm just been told off for not mentioning people from Colombia, Belgium, and Romania. So welcome more people from around the world. All yours, Phoebe.
I'm going to share my screen. Well, hello, everyone. Thank you so much for joining us, and to the meeting organizers for inviting me to speak today about the topical management of ocular cystinosis. I'm going to be talking about the drops that are currently available in the United States to treat this condition, some of the studies that led to the drop development, and also hopefully open up a discussion on some of the ways that we can improve eye drop compliance, since the eye drops, as the speakers before me have shown, are so critical to achieving a good outcome for these patients. So crystal accumulation in the cornea and conjunctiva is the pathognomonic ophthalmologic finding in cystinosis. And in most of these patients with cystinosis, these cystine crystals in the cornea are present at birth. They start forming at birth. Crystals can be visible by as young as 12 months of age, but are visible in most patients by 18 months of age. And this is probably the best photo that I've ever been able to obtain of a patient with cystinosis, mainly because of their light sensitivity. It's hard for them to open their eyes on the slit lamp exam to the bright light. Cystine crystals occur in all layers of the cornea, from the epithelium and the stroma and the endothelium. And as Dr. Grimm mentioned, the deposition begins in the anterior periphery and then progressively goes deeper into the corneal layers over time, more centrally and deeper into the stroma. So deposition of these crystals occurs in the other eye tissues as well. And this was a nice image of these cystine crystals in the conjunctiva. You can see them here. And these are pointed, needle-like, highly refractile crystals, and they look like shards of glass. And so why does this happen, and what can we do about it? A lot of this has already been described by the previous speakers. So, this is associated with mutations in the CTNS gene. And this gene is responsible for making cystinosin, which is the transporter protein to get the cystine out of the lysozyme. But the problem is that in this condition, the cystinosin transporter protein is defective, not functioning properly, so the cystine accumulates over time in the lysozymes. So what can we do about this? Cystine crystals are depositing throughout the body and in the eye, and this is a nice graphic here that shows figuratively the accumulation of crystals throughout the body and through all of the layers of the eye tissues. And so for patients with cystinosis, they really require concomitant systemic and topical therapy, as both of the speakers before me have pointed out. From a systemic standpoint, it's very nice to have a relationship with your patient's nephrologist. Cystine depleting oral medication reaches the organs through the bloodstream. And so the problem is that because the cornea is an avascular tissue, topical treatment is also required in addition to systemic therapy to manage the corneal cystine crystal deposition. There are currently 2 concentrations of topical cystamine eye drops available in the United States. The first is cystamine 0.44% solution. This is marketed as Cystoran, and this was approved by the FDA in 2012 as an orphan drug to treat the ocular manifestations of this disease. So this treats the cystine corneal accumulation in the cornea of patients with cystinosis without the need for that malfunctioning protein in the lysosomal wall, the cystinosin. That's the lysosomal transport protein that usually takes the cystine out of the cells. The drops are stored frozen, and what happens is the family takes the drop bottle out of the freezer and allows it to thaw, and then they use it for a week and then discard the bottle. Once the drop is defrosted, it should not be refrigerated again. And the usual eye drop precautions apply when using these eye drops. So the dropper tip shouldn't come into contact with the ocular surface for infection control reasons. contact lenses should be removed for about 15 minutes around the time of the drop administration, because these drops do contain benzalkonium chloride as a preservative, and that can become concentrated and absorbed in the contact lenses. The second drop is cysteamine 0.37% ophthalmic solution, and this is marketed as Cysta drops. This drop is very viscous, so it spreads over the entire cornea and penetrates deeply to reach the cystine crystals in all layers of the cornea. The dosing for this drop is 4 times a day compared to the Cystaran drop. The Cystaran drop, the dosing schedule is once every hour while awake. So one study of the Cysta drops showed a 12% reduction in corneal crystal deposition after 30 days and a 40% reduction after 90 days. Now, it's important to note in the United States, both of these drops must be obtained through specialty compounding pharmacies. So both concentrations of cysteamine have the same mechanism of action. And this has already been discussed by Dr. Grimm, so I may not go into great detail here. But again, the problem is the defective or missing cystinosin, which is the lysosomal membrane transporter. And what happens is the eye drop, the cysteamine, binds to the cystine, and the bound form of this can then exit the cell through an alternate transporter. The clinical efficacy of the cysteamine 0.44% ophthalmic solution, Cystaran, was evaluated in controlled clinical trials involving about 300 patients. And the primary efficacy endpoint was the response rate of eyes that had a reduction of at least 1 unit in something called the photo-rated corneal cystine crystal score at some time point during the study when the baseline score was greater than or equal to 1, or there was a lack of an increase of more than 1 unit in the corneal cystine crystal score throughout the study when the baseline score was less than 1. So you can see here some of the slit lamp photos demonstrating the decreased corneal crystal deposition over time. And this was for a 5-year-old patient, the top images before and after 15 months of treatment, and for a 25-year-old patient, and these are the images in the lower half of the screen, before and after 12 months of treatment. It should be noted that if you stop the medication, or if the patient's family stops the medication, then these corneal crystals will reaccumulate over time. So this requires chronic therapy. And again, both of these drops must be obtained through specialty pharmacies in the United States. So this is going back to the original paper that both speakers prior to me have noted by Dr. Gall and co-authors. And this is a library of representative slit lamp photographs showing the various stages of cystine crystal deposition in all layers of the cornea from 0 to 3 in increments of 0.25 units. So I thought it was very interesting to go back to this original paper, particularly for those of you who do see these patients as ophthalmologists, and think about what level of cystine crystal deposition the patient in front of you has, and has that improved over time or has it not? And if so, then probably they're using the drops. And if it hasn't, then perhaps they're not receiving the drops as frequently as they need to. The Cysta drop study showed that in vivo confocal microscopy can also provide precise histologic assessment of the cystine corneal crystals. And over time, for patients receiving the Cysta drops or the 0.37% ophthalmic solution, in vivo confocal microscopy demonstrated reduction of these corneal crystals in all layers, as shown here. It was interesting to me that anterior segment OCT can also be used to document progression of corneal crystal deposition over time. So these are actually anterior segment OCTs of different patients that demonstrate varying levels of pathology in these patients. But you could also use it over time in the same person to document progression. The top photo, patient 1, had depth of crystal deposition noted to about 111 microns. The middle photo, patient 2, had corneal crystal deposition to about 296 microns, and the bottom photo, patient 3, had crystals to about 368 microns. So shown here are some of the side effects of these topical treatments, and these occurred in at least 10% of patients receiving these medications. So with the Cystaran, patients experienced photophobia, eye redness, eye pain and irritation, and headaches. And with the Cysta drops, they experienced eye irritation, blurred vision, ocular hyperemia. Some had itching of the eyes or increased lacrimation. These drops really do sting, which I think we're going to discuss as a group, and this definitely can limit compliance, which leads me to how to improve drop compliance in kids. So, unfortunately, there's not really a good way for us as physicians to monitor compliance other than asking families and children, are you using your drops? We can monitor the clinical effects of the treatment by, again, slit lamp, progressive serial photographs of the corneas, using the corneal cystine crystal score, in vivo confocal microscopy, as I mentioned, or anterior segment OCT. But we're not doing research studies with clinical patients. In research studies, you can weigh the bottle to see if the eye drops are being used. We can only really ask or see how many times a patient has refilled the medication since the last time that we saw them. As so with so many of the conditions that we see as pediatric ophthalmologists, education is critical. So patients' families really need to be aware of the long-term manifestations, the signs and symptoms associated with cystinosis, and particularly the corneal crystal deposition. So anterior segment complications occur mostly in older cystinosis patients, but these include the superficial punctate keratopathy, the filamentary keratopathy. You can see band keratopathy and peripheral corneal neovascularization can mostly in post-transplant patients later in life. Posterior synechia can occur with iris and angle abnormalities that can lead to pupillary block and ptysis. Some ocular symptoms are due to the effects of the cystinosis on other systems. So, for example, reduced tear production can be leading to dry eyes, can result from the impact of cystinosis on the endocrine system. Retinal degeneration and optic nerve elevation with intracranial hypertension has also been described. However, many of these patients are on chronic steroids and have chronic renal failure, so there are a lot of confounding factors. The photophobia certainly can progress over time as children and turn into adults and get older, and this leads to the severe blepharospasm that we often see. The patients that are in your chair blinking like this, it can be very, very difficult to obtain a slit lamp exam. And older patients can also experience decreased color, peripheral, and night vision. So all of these things over time can lead to decreased visual acuity. And you can show parents the before and after treatment photos that I showed before. They're available on some of the websites for the topical treatments. And you can focus strongly on how the drops will improve their child's quality of life, stressing that not only does the medication reduce the topical not only does the topical medication reduce the corneal crystal deposition, it also significantly improves the symptoms of the photophobia, the blepharospasm, and the eye pain that many of these patients experience even early in life. So for families for whom compliance is a real issue, sometimes I'll show them a photo of long-term outcomes for untreated patients prior to the availability of these newer eye drops. So I think that supporting these patients and their families is really hard, but I think that as pediatric ophthalmologists, we're uniquely equipped to do so. We're used to working with patients and their families to improve patching compliance for amblyopia therapy. We're used to working with families of these children with glaucoma to improve their eye drop compliance for lowering intraocular pressure. It's important to encourage timing drop dosing to coincide with their daily activities, such as breakfast, lunch, dinner, bedtime. Setting a timer or a digital reminder can be helpful for medications with more frequent dosing, and also making sure that the school support systems are in place as well, keeping in mind what Dr. Grimm mentioned in his talk, not forcing the issue too much. The development of reward systems and families can also be helpful. With patching for amblyopia, so we sometimes use posters like this. It's called a patching poster, where patients place their used patch on the picture to come up with a colorful mural by the end of the treatment month, and that may encourage compliance over time. But overall, when you review the literature regarding medication adherence, not just in ophthalmology, but in other specialties, particularly glaucoma, there's really very limited evidence behind a lot of these strategies. So this Cochrane review in 2013 looked at interventions for improving adherence to ocular hypotensive therapy, and they involved a large number of patients, 1,500 patients. And some of the studies looked at education, some looked at combining education with behavioral change interventions, such as the tailoring of daily routines. Some studies looked at different drug regimens. Some of them looked at a reminder device, but there really wasn't a huge amount of data to support any of these interventions. Another study indicated that for patients who have other disabilities, sometimes that can make compliance with drops and medication in general much more difficult. Finally, the last study I wanted to mention was the one on the lower right, the interventions for glaucoma medication adherence improvement that was published in Ophthalmology in 2022. This indicated that a multifaceted approach, combining tailored care with other things like multimedia education and device reminders are probably the most effective in terms of bolstering compliance in your patients. In the pediatric realm, this was an article in the British Journal of Ophthalmology in 2016 that concluded that interventions to increase patching compliance should include educational components, but also that more high quality research is necessary to see how we can develop these additional behavioral change interventions to improve compliance in our patients. So thank you for your time and attention.
No, thank you very much, Phoebe. It was really incredible, of course, because you just explained that the games may be the very good way for children to have a better compliance. And so you explain also how these eye drops are really different. So do you have any question? Would you like to speak, Ken?
Yeah, so we have lots of questions from the audience. Let's kick off a question for Professor Grimm. Before somebody starts topical treatment for the crystals, is there any correlation between the crystal grading and the renal disease that you're aware of?
I've never read that there is.
That's my understanding, I have to admit.
That's a great question. Mm-hmm.
Yeah, so that was a question from Dr. Shabana. Dr. Biswas, Sas Biswas from the UK, wants to know, Dominique, what's your experience of patient feedback if you switch from the aqueous cysteamine hydrochloride? So in the UK, they don't have cysteran, they have a 0.55% aqueous. And he says, what's your experience switching from the aqueous to cyster drops from patient feedback? And that's a question I'd like to ask the whole panel, really.
Yeah, I think it's for all of us. I think the main point is less instillation. The problem was every hour. So it was very complicated. And so we have now decreased instillation of the eye drops. So the feedback is good. Do you have the same experience, or?
Phoebe or Paul?
There are a few patients who find that they prefer the original drops because they find that the drops take so long to drop from the dropper. It's almost like an anticipation thing. There are some patients that just want to get done, just boom, boom, go. And so they actually go back. But it's very much a preference thing. And I do say, but look, you're going to have to do the drops so much more frequently. You could do it less, especially if you do an evening one. But it's just a preference because the drops are thicker, and there's just a preference thing. So some patients call the cysteran drops cystagoop. But yeah, I've seen a few of those. Yeah.
Phoebe, what about you?
Had the same experience.
Okay, so here's a question that I think is quite interesting. Dr. Grandy says there is no access to eye drops in developing countries. Any comment about pharmacy prepared eye drops from the Cystagon capsules?
Wow. So in the United States for many years, compounding pharmacies would mix up the drops. There were a number of different compounding pharmacies that would ship them frozen, and the patients used them, and it did reasonably well. One of the things that was really interesting was when they were forced off the market because the FDA approved the commercial drops, patients did complain more about stinging. And the commercial drops have the buffers and the preservatives that cause more stinging, whereas the ones that were produced by the compounding pharmacies didn't necessarily. So some of the patients wish that they could go back. So I believe it can be done. I believe there are prescriptions out, recipes out there, and in certain parts of North America, even in Canada, some hospital pharmacies still compound it. Now, I don't know if they take the pills and use the pill, or they get the medicine from a chemical supply house. But there are recipes out there, and they had been successful for many years in some places.
Thank you. So, Dr. Tibrewal from New Delhi, she's asked a really interesting question. She says, if we can start off with lower drops, what frequency would you suggest? And then should we increase the frequency if we find there's no correlation? So I guess this is for the aqueous drops, or maybe even in the sister drops, that, you know, what's the lowest frequency that you've ever started somebody on? Or have you always just started at, you know, hourly for the aqueous and the for the ones with the gel 4 times a day?
I can't answer for that because a long time ago there was no compliance, so sometimes they had only twice a day, and we were recommending 6 times a day, but in effect it was only twice a day, and it was very bad result. So I don't think if we have only twice with regular initial treatment, it was enough, and at least it was 6 times a day, to my thinking.
Yeah, Phoebe?
I'm not sure that I know the answer to that question. You know, I think I just try to get the patients to use the aqueous form, the Cysteran, as frequently as they possibly can. You know, most of them are not using it every hour while awake.
So there's a really good question about conjunctival involvement. So you mentioned this, Phoebe. How often do you see conjunctival involvement, and how, you know, does it change what you're doing?
Well, I think sometimes you can see the conjunctival involvement at the slit lamp. You can see, I didn't show a photo, a slit lamp photo, but you can see, you know, the conjunctival crystal deposition in the conjunctiva at the slit lamp using, you know, certain lighting techniques. I think, you know, we know that the crystals are forming in other areas of the eye as well. So, you know, it's just another component of the exam that I use to guide therapy and to try to convince families of the importance of using the eye drops according to schedule. I think they can be very uncomfortable for patients.
Dominique?
Yeah, I really think the point is when you just look at the crystals on the conjunctiva, you think that there is no impact on the vision because it's not cornea. The problem is there is probably an impact because it impacts the goblet cells, for instance, probably, and so it affects the ocular surface. So that's why I think it's important. But to my knowledge, I think I do observe much less in conjunctiva than in cornea. And I don't know why, because there is no, I have no explanation for that. But for sure, if you see crystal on the conjunctiva, you need to put some eye drops, lubricants to get back to a good ocular surface, to my thinking.
So what I found, again, this is anecdotal. When I was in England, I saw a much bigger age range, and the older they were, I would find, like in the late teens, that they were blinking a lot. And it wasn't necessarily photophobia. Those are the ones where the conjunctiva was involved, and it was staining. And in 2 of them, I convinced them to let me put punctal plugs in. So, Paul, we have drainage areas, a punctum at the bottom of the lid here and one at the top. And if you put these silicone plugs in, the tear film hangs around a bit longer, even if it's reduced. And I also found that the application of the frequency of the drops could go down. So I haven't had to do that here in Pittsburgh, but I wonder if that's a strategy we could use if there was a problem. We've got a couple of other questions. This is for you, Paul. any gene therapy coming down the line, and in any of the gene therapy trials, has the amount of ophthalmic involvement reduced enough not to need drops?
So at UC San Diego, Stephanie Shirkey was the PI for a gene therapy trial where they used a lentivirus vector to gene correct 6 patients. Of those patients, 5 are off cysteine depleting therapy. They have had adequate number of vector copies incorporation, and so their blood white or granulocyte cysteine levels have been good, and the patients have symptomatically been very good. I don't recall if they're all off the drops, but I remember watching a presentation where at least 3 of them were nodding their head that they had not been on the drops, and to their surprise, their crystals were stable. I don't know what the follow-up is, and that's very preliminary. So these patients were adults, and they are in follow-up. The intellectual property now is in the hands of Novartis, and Novartis is working on bringing a next phase gene therapy trial to approval of regulators in the United States and in Europe. Don't know much about it. It's still very much in the planning stage. So you now have to stay tuned. So we're all waiting very anxiously. Yeah.
Well, that's excellent. Thank you. Got 2 more questions before we move on. Do both the Cystaran and Cystadrops need to be kept in the refrigerator? I think you answered that, Phoebe, to some extent, didn't you? Do you want to just reiterate that if that wasn't clear?
Sure. So once the drops are defrosted, they should not be refrigerated. There's a specific temperature range that they need to be maintained at, and it's a room temperature.
Okay, thank you. And then Sas Biswas from Manchester says, in my experience, that there is 100% conjunctival involvement in my group of patients, particularly noticeable at the limbus. What I don't really understand is why the systemic cysteamine does not work. So that's interesting. I think probably if we all looked for it, it probably is involved. I hadn't noticed about the limbus, but that's something I'll look out for. And then we have Dr. I'm not going to say the name right, so I'm just going to say Dr. Marco. Dr. Marco went with the crystalline gammopathy that you see, or keratopathy that you see in monoclonal gammopathy, is very different to cystinosis. Tends to be more central. You don't tend to see it diffuse. So, and the treatment is really treating the myeloma or the monoclonal gammopathy. There's no topical treatment for that I'm aware of, and it's a completely different appearance. Would my ophthalmology colleagues agree with that?
Yeah, I agree too. That's true. It's different.
Okay.
Right. So thank you very much, Ken, and thank you for all these question answer for the question from the floor. And so now, Ken, hope you will speak about ocular sign in long-term survivors of cystinosis, because we have many things to understand. Thank you very much, Ken.
Thank you. So this paper came out, which I found really useful, Adult Complications of Nephropathic Cystinosis, a systematic review. Look, what I found is that the ocular signs can be direct ocular or visual signs, or they can be indirect. And when you look at the age-related clinical characteristics, we've obviously talked about the renal disease. Hypothyroidism is something that I've seen twice in late teens. And I saw it because of a change in their mood and affect. And when I saw it, I asked for their thyroid to be checked. And in fact, it was going to be done anyway by their pediatrician. Photophobia in 50%, the myopathy that Professor Grimm has talked about. We'll talk about retinal blindness in about 10 to 15%. And I want to talk about the central nervous system as well, because we need to be aware as ophthalmologists of what can happen. Increasing photophobia, I think that we're going to see less of that now with the different drops that we have and the different strategies that we can use. The erosions can be really problematic. I remember a wonderful patient who was about 25 years old, had terrible erosions. We used contact lenses. In the end, she had an automated lamellar keratoplasty done because it was so bad. And the relief was short-lived. I mean, after 2 years, she was back to where she started. But she was very pleased for that 2 years of not having extreme photophobia and recurrent erosions. This is a paper by Cystinosis Biswas, who I'm very proud to say was a fellow of mine 25 years ago and has surpassed anything that I could have ever done in pediatric ophthalmology. And he has done a lot of work on metabolic diseases affecting the eye. This was a really nice score that I've begun to use. So if I do a telemedicine, I use the self-assessment photophobia score, and I suggest that you use it as well to try and gauge if things are getting better or not. One of the things that I found was ocular pain can be something that can be somewhat confusing. If they haven't got erosions, then and they're a little bit older, beginning of the second decade, for example, I do think about glaucoma, and I do think about hypoaccommodation. In fact, I saw a child just 5 days ago who's 8 years old, has been investigated to the hilt, and has this headache. And when you ask the child, where is the headache? She points to the middle of her forehead and then says, it does this. And that's, asthenopia, which we should recognize. And when I was a fellow at Sick Kids in Toronto, we did this study about ultrasound by microscopy in the cystinotic eyes. And I just want to show this schematic. If you remember that these cystine crystals can be deposited everywhere, and they can be deposited in the iris. So as they get older, the iris doesn't dilate, the pupil doesn't dilate as well because the iris becomes stiff, but they can also be deposited in the ciliary body, ciliary processes, and also in the ciliary muscle itself. So in this study, we looked at 6 patients with infantile cystinosis, 6 age-matched controls, and basically what we found was that the scleral reflectivity, corneal and iris thickness, central anterior chamber depth, they were all different to the age-matched controls. And what I want to show you is the reflectivity was increased, not a big surprise, but the angle was narrower. And it was narrower because the ciliary sulcus was closed or narrow. So if you look on the left, the 3 pictures on the left are all children with cystinosis. The ones on the right are the age-matched controls. And you are beginning to develop what we call a plateau iris configuration. So if they're getting headaches, ask them if they're happening in the evenings. And if they are, you may be looking at subacute angle closure attacks. And I've actually had to use pilocarpine. I have never tried to do iridoplasty because I didn't know if the laser would be able to get through the cornea, and I didn't know how the uptake would be if there were crystals in the iris stroma. So I have resorted to using pilocarpine. In this particular case, there was a clear angle closure glaucoma because of a cyst of the pigment epithelium in a child with cystinosis. So the reports of glaucoma are increasing as the older the survivors get. The mechanism can be explained by what we're seeing, and also the mechanism of the hypoaccommodation can also be seen. So while I agree that we don't need to start the drops immediately, I just do wonder if starting the drops at a slightly earlier age may affect some of the things that we're seeing later on, such as secondary glaucoma and accommodation deficits. This is a patient of mine. This patient was from Great Ormond Street, and you can see that there's a sort of a bullseye maculopathy starting. That's much rarer in children with cystinosis affecting the retina. They tend to get this pigmentary disturbance. But what I do now is I always get a baseline, and I will get an electroretinogram as a baseline. If I start to see changes in wide field fundus imaging, then I will, or I can't explain the vision drop, then I will repeat the electroretinogram. And this is one of my patients. I have always felt that the tear film gets worse as they get older. And I've wondered if some of the stinging that we see is because of the pH changing. And when I have children who complain a lot of stinging, I'll ask the parents to put a artificial tear in just before they put the actual cysteamine drop in, whether it's Cystaran or Cystadrops, and that seems to help. However, this study came out where they said that the tear osmolarity was no different between children treated with Cystadrops and children not treated. So I don't know if children who are not compliant actually genuinely do have more dry eyes because of reduced production of tears, which makes sense because you'd expect the cystine to be deposited also in the lacrimal gland cells. I think the neurological involvement is very important. I have seen one child who started to bump into things and actually had a stroke-like episode and had a homonymous hemianopia. And there are two types of neurological involvement. There's a cystinosis encephalopathy and a stroke-like episode. Now, the encephalopathy I have not seen here while I've been in the USA, but I had a couple of patients who developed hypometric saccades. Their ability to look to the left and right, look up and down was limited when you checked for it. And that's because of cerebellar involvement. And this is the MRI findings from this study that I just showed you. Isolated ventricular dilatation, perivascular space enlargement, and cortical atrophy. So I think it's something we should be aware of. If children are complaining of headaches, there are two things to remember. Children with cystinosis have a 12-fold increase in the incidence of Chiari-1, and so it's important to check that the nerves are not swollen. And also there's a higher, well, not higher incidence, but there have been reported cases of idiopathic intracranial hypertension and hydrocephalus. Now, if the child is difficult to examine, I have resorted to using ocular ultrasound to see if the nerve is swollen. We've had a wonderful explanation about this. What I do want to say is, I do want to say that what I have found is that those children who have been using Cystadrops, this is an older child from the UK. This is a child who's 8 years old. I saw her 4 days ago, the one who had the accommodation problem. Her crystals have almost disappeared. And I don't know if it's a compliance thing, if psychologically the parents think, oh, I only need to put the Cystadrops in 4 times a day, or whether it is genuinely that the way that the drop is compounded, that it or made, that it's getting into the eye better. I have no idea. I know that Cystadrops can be expensive. Some insurances won't cover it. So it's important that we use the drops that are available and perhaps modify the treatment, maybe use tear plugs if necessary. Just think about strategies to try and improve the outcome. So in summary, photophobia, ocular pain, eye movements, headaches. Children are bumping into things or develop a head posture, head turn. Think about a homonymous hemianopia, let's see how we can improve these children's lives. Okay, I think do we have some more questions?
I have a question.
Yeah.
So I'm very interested to ask about the timing of the last dose of the day of the Cystadrops. So I believe that the package says have the drops like shortly before going to bed, 10 or 20 minutes before going to bed. But some patients will put the drops in and then immediately close their eyes. And I've been thinking that's a good idea because the eye isn't moving, they're not tearing, and so it sits against the cornea for the longest time, and that might do a much better job depleting the crystals. In the morning, sometimes they will be a little bit sticky and they just wash their eyes off and they're fine. But I'm wondering if that's actually if some people are doing that, could that be why the crystals look so beautiful in some of these patients?
I tell them to do that. I say, put the drops in, close your eyes, and let the child go to sleep. Don't let them run around after you've put the drops in. Put them while they're in bed. That's what I do. I don't know what the others do.
Maybe a PM ointment formulation would be desirable.
Dominique, you're muted. That's why we can't hear you. Apparently, that was the most famous phrase in 2020 and 2021. You're muted. Go ahead. Yeah.
So sorry, but I will do that because I don't give this advice to my children treated. And I will say to the parents that it's better just before going to bed and nothing to do for the children. That's true. That's a good option. And it's very complicated also. And we must be aware also of lubricants, because lubricants shouldn't be instilled at the same time also, because they will probably diminish the action of the Cystadrops, for instance.
So I have to tell you that I asked them to use preservative-free Celluvisc
Yeah.
because it's very thin. It's not viscous. But I found that sometimes helps them with dealing with the stinging. Now, I haven't found a decrease in the efficacy of the crystal decrease, but maybe that is something I should look out for. There's a comment about the fact that in Asian children, this again from Dr. Biswas, there is often a subtle peau d'orange appearance of the RPE in the mid-peripheral retina, which you don't see in lighter pigmented children of European descent. That's very interesting. I'm going to look out for that.
I will try to do
something I've noticed. Paul, can I ask you, we're sort of coming towards the wrap-up end of this. Is there something that you think, so I always say to my fellows, you're an ophthalmologist second, you're a doctor first, especially when you're a pediatric ophthalmologist. Is there anything you'd like us to look out for? Like, suppose, sometimes we have children who they come to see me, they're supposed to see their nephrologist, and they missed that appointment. Now they're going to see them in 3 months. Is there anything that we could see and notice about the child as a whole that we might be able to stop them running into problems and get a hold of the nephrologist, or not let them leave the hospital till they see a pediatrician? From your perspective?
Throughout the presentations of various speakers, there has been some discussion of increased intracranial pressure and headaches, growth hormone, which many of these cystinosis patients are on, steroids for immunosuppression, and the cystine crystal buildup in the drainage of the CSF all can cause individually or in combination increased ICP. So if the headaches are late at night, early in the morning, that might be ICP. Or as you said, if the headaches are in the evening, that might be a subacute angle closure. So being aware of headaches is important. The other thing is, in my adult practice, over 40% of the patients have migraines. And this is something which I was unaware of, but Doris Trauner, who's a neurologist who knows the cystinosis field, has identified that as well. And so as an ophthalmologist, if they talk about headaches, just be aware that migraineurs there's a high percentage of migraineurs in the cystinosis population, and all the therapies that are used for migraine, the special glasses that block certain wavelengths, the different B vitamins and things like that, and more pharmacologic therapies are all used in many of these patients.
Fantastic. So I think we're coming up to the close. We really have had a phenomenal presence on YouTube. Can I ask one pearl from each speaker and moderator? So I'm going to let Dominic, you go first. We'll go with Paul last.
Thank you very much. So one pearl is just the examination. When you have seen these crystals, you won't forget it, and so send it to the pediatrician. That's very important. Second point, which is not a wrap-up, but for the ERN, for the country that are not in ERN, they can go inside and just look at the forum, and they can present cases and let me know if you need that. So that's the second point for ERN network.
So yeah, that was a question. So if you're outside Europe, you can still participate, and perhaps Paul, you, me, and Phoebe should get together and see if we can create a similar network in the United States.
No, we create
I'm sure there is one that I just don't know
about.
about.
Not another network.
Phoebe?
I think the pearl that I would offer would be something that we all touched on, but just support and empathy for these families and what they're going through. Recognizing the large number of subspecialty providers that they must see on a regular basis, the fact that many of my patients are traveling 3 to 5 hours to see me. Sometimes it can be difficult to get the drops. You're asking a lot of the child and the parents. So just trying to be as supportive as possible while getting them to be as compliant as possible, and finding that balance is probably the most important thing.
I'm going to my pearl that I really have taken from Paul is assess the child. If you see a child on one occasion that looks healthy and well, and then you see them the next time and they look dehydrated and the skin looks sallow, just don't worry. Just don't worry about the eyes alone. Just make sure that there's a question about how the child is doing, are they hydrated, and get a pediatrician to see them before they leave the hospital. That's my pearl. Paul?
So I have to support what Phoebe said, recognizing the complexity of life. And, as physicians, we have the best outcome possible is what we want. We tell people to do everything, but oftentimes good enough is good enough. Doing the best you can, saying, maybe we can do a little bit better later, but we have other things going on. And just being kind to yourself, whether you're a physician for these patients or whether you're a patient or a parent, just being kind to yourself and recognizing we all are imperfect and we do the best we can and we keep trying.
Thank you so much. So I have some housekeeping to do. Audience questions. If we've missed any of your questions, email them to admin@wspos.org and we'll respond to them and get back to you. Now, there's an upcoming WSPOS webinar in association with the International Topical Association. It's webinar number 3, season 5 in April. Look out for that, focusing our attention on accommodation-related disorders. We're looking forward to that already. Of course, I have to talk about the World Congress of Pediatric Ophthalmology and Strabismus, number 5, in conjunction with the 14th Malaysian Society of Ophthalmology annual meeting in Kuala Lumpur, 11th to the 13th of July. This is the Petronas Towers, as all my Argentinian friends will tell me. The architect was Argentinian. I know. I've been told many times. This is Malaysia. If you come, remember from Kuala Lumpur, you can get to Singapore, Thailand, Burma, Indonesia, all these places that perhaps you would never have visited, but you have an excuse to do so. We have great keynote speakers. We have Professor Stephen Kraft, Professor Vijay Lakshmi, and Professor Shigeru Kinoshita. And for those of you who don't know, Professor Shigeru Kinoshita is the man who developed the ROCK inhibitor drops. He is the man who has done all this work on repopulating endothelial cells. So a real icon in the world of adult ophthalmology who's given to pediatric ophthalmology. Stephen Kraft, do I need to say anything about the legend that is Stephen Kraft, the strabismologist? And of course, for those of you who don't know Professor Vijay Lakshmi, she works at Aravind Eye Hospital, and that whole system treats millions and millions of people through their pyramid systems, and they are absolutely phenomenal. A wonderful festivity. Now, the abstract closing date is the 4th of March, but as always happens, there's been a meltdown in our website because people have been last minute trying to put the abstracts down. So I can tell you we're extending it for 2 weeks. Don't panic. Don't panic. We're extending it for 2 weeks so that whoever wants to put it in can just go easy on the website. The poor thing is on its last legs. This is the programs already done, 250 speakers, invited speakers from 52 countries over 3 days, and there's going to be a lot of partying in between, so I hope you'll be there. Please join us at WSPOS. Membership is free, will always be free. If you want to be part of the international listserv that David Granite runs, email him, give him your name, where you did your fellowship training, and your current place of employment. So, thank you so much to our audience. I really genuinely can't thank Paul Grimm enough. You really have brought a whole new attitude to our audience, and it's been a pleasure listening to you. Thank you so much. Phoebe, as always, Professor Lenhart, what an amazing speaker. Dominique, my co-moderator, you are a star and a sister from another life, as you know. And it's been a pleasure watching everybody and learning from everyone. Recordati Rare Diseases, thank you for the educational grant for us to be able to hold this. Todd for supporting the platform, and Akila Acharya, our admin. I'm going to stop sharing on that note. Thank you very much indeed.
Thank you for moderating.
Thank you.
No, absolutely. And I hope if anybody's interested in helping develop a global network, email admin@wspos.org, admin@wspos.org. And we will try and do this so that pediatricians and ophthalmologists and nephrologists especially are talking to each other about these wonderful children. That's it. Any last words?
Have a nice day. Bye-bye.
Yeah. Have a nice evening, a nice day,
weekend.
a nice night.
Thank you.
Thank you, everyone.
Thank you very much.